Hey everyone, and welcome to This Explainer. Today, we're skipping the basic, surface-level summaries and diving straight into the exact clinical pathways for diagnosing and managing stress-related disorders. We're getting right down to the nitty-gritty, the precise criteria, the strict timelines, and the concrete, evidence-based protocols that clinicians actually use out in the real world. So, if you want to understand exactly how psychological trauma is categorized and treated, completely without the fluff, you are absolutely in the right place. Let's get into it.
We've got a pretty packed roadmap today. We'll be systematically breaking down acute stress disorder, post-traumatic stress disorder, adjustment disorders, and finally, abnormal grief.
Okay, let's dive into our first module, acute stress disorder, diagnosis and management.
Now, the diagnostic timeline for acute stress disorder is incredibly strict. Day 0 is the event itself, and we're talking about an exceptional stressor. This isn't just a tough day at the office, right? We're talking about actual or threatened death, serious injury, or sexual violation. But here is where the clinical diagnosis gets super precise. Symptoms actually have to begin at least 2 days after the event. And crucially, an ASD diagnosis maxes out at exactly 4 weeks. If you're looking at symptoms on day 1 or way out on week 5, you're simply no longer looking at acute stress disorder.
So what exactly are we hunting for within that strict 2-day to 4-week window? Well, the diagnostic criteria require exactly 9 symptoms, and they have to be drawn from 5 distinct categories. You need a mix of intrusive memories or dreams, dissociative reactions, which is where the patient actually loses touch with their surroundings and feels like the event is literally recurring, extreme distress to physical or psychological cues, arousal symptoms like severe insomnia or hypervigilance, and active avoidance of any reminders. It's a really comprehensive checklist, and it ensures we're capturing a profound multi-system psychological and physical reaction.
When it comes to actually managing ASD in those chaotic first few weeks, the protocol might honestly surprise you. It's essentially psychological first aid. Step 1 is just providing basic protection. Then ensuring physical care, reuniting the patient with loved ones, and helping to facilitate a sense of control. You'll notice that heavy pharmacology is nowhere to be found in these primary steps. In fact, medications like anxiolytics or hypnotics are strictly reserved for only the most severe anxiety or profoundly disrupted sleep. And even then, we're only talking about giving them for maybe 1 to 2 days.
Now, what's really interesting about this next point is that it myth-busts a super common misconception. A lot of people think sitting down and immediately debriefing a trauma survivor, basically making them talk through the event right after it happened, is the best course of action. But current clinical evidence actually suggests debriefing at this acute stage may be harmful. Pushing someone to process trauma before they're fully stabilized can actively exacerbate the condition. Why does this matter so much? Because it completely challenges our human instinct to immediately talk it out, proving that sometimes the brain just needs safety first before it can even begin processing.
All right, let's transition smoothly over to Section 2, post-traumatic stress disorder, diagnosis and management.
So what happens when those 4 weeks pass and the patient just isn't recovering? This is where the diagnostic categorization evolves, and the crucial point is the timeline. The stressor is the exact same exceptional event we just discussed for ASD. But for a PTSD diagnosis, those clinical symptoms must last beyond 1 month. It's also incredibly important to note here that PTSD can actually feature a delayed onset, where symptoms might not even bubble to the surface until 6 months or more after the initial trauma.
Before we look at the specific symptoms, we really have to look at this statistic. 80%. A staggering 80% of PTSD cases feature co-occurring disorders. We're talking about depressive disorders, anxiety, bipolar disorders, and substance-related disorders. Clinically, this completely dictates the management pathway. For example, if a patient presents with a substance use disorder alongside their PTSD, the clinical protocol demands that the substance use disorder absolutely must be treated first.
To formally diagnose PTSD, clinicians use very strict symptom thresholds across 4 key domains. A patient needs 1 or more intrusive symptoms, like recurring nightmares. They need 2 or more negative cognitions or mood changes, think persistent negative beliefs about the world, or anhedonia, which is the inability to feel pleasure. They also must show at least 1 avoidance behavior, and finally 2 or more arousal symptoms, such as reckless behavior, angry outbursts, or an incredibly exaggerated startle response.
So once diagnosed, how do we actually treat it? Well, psychotherapy is the frontline defense, specifically trauma-focused cognitive behavioral therapy and EMDR,
which stands for eye movement desensitization and reprocessing. This is truly fascinating stuff. It's a highly specialized psychotherapy that uses targeted eye movements to help the brain literally reprocess traumatic memories so they are no longer emotionally overwhelming. It's a primary, evidence-based intervention that we turn to before we ever even reach for a prescription pad.
And this brilliantly illustrates our exact pharmacological protocol for when medication is actually required. It's highly targeted. SSRIs, SNRIs, and TCAs have the strongest evidence base. Prazosin, which is a specific receptor antagonist, is prescribed uniquely to combat nightmares. Low-dose trazodone is brought in specifically for severe insomnia, which, as you can imagine, is highly prevalent and disabling in chronic PTSD. And perhaps most importantly here, benzodiazepines are explicitly marked to be avoided. They are simply not recommended for PTSD management, period.
Moving right along to Section 3. Let's see how this builds into adjustment disorders.
Now, the timeline here is a completely different ballgame compared to what we've seen so far. Unlike ASD and PTSD, which stem from severe, life-threatening trauma, adjustment disorders arise from adapting to new, stressful life circumstances. Think a difficult divorce or a sudden job loss. You have an identifiable stressor at month 0. For an adjustment disorder diagnosis, the emotional or behavioral symptoms must start within 3 months of that stressor. And here's the defining boundary. Symptoms do not persist for more than 6 months after the stressor or its consequences have ended.
But, obviously, it's not just about feeling stressed. It has to meet real clinical criteria. The patient's distress must be measurably out of proportion to the severity of the event, or it must cause significant impairment in their day-to-day functioning. Interestingly, research shows there is a surprisingly strong genetic component here that makes certain individuals much more vulnerable to these disproportionate reactions to life changes.
Because the trigger here is a life circumstance, the management protocol strictly focuses on practical resolution. We really want to aid natural adjustment processes. This means reducing denial, actively encouraging problem solving to deal with the stressful event, and using group therapy or discussion to help the patient express feelings and reduce anxiety. Why does this matter? Well, because we're treating a life transition here, not a chemical imbalance. Heavy pharmacology is definitely not the answer. The entire goal is just equipping the patient to navigate the life change. Okay, that brings us to our fourth and final module, abnormal grief. Let's look at the exact clinical markers for when normal grieving crosses the line.
Look, grief is a universal human experience. We all go through it, but there are exact clinical markers for when normal mourning crosses that line into pathology. Normal grief involves fairly predictable stages: temporary denial, depression, and ultimately acceptance. Pathological or abnormal grief looks completely different. It is delayed, unusually intense, and prolonged. It's marked by persistent avoidance of reminders, intense disbelief, deep anger about the death, and this overwhelming, pervasive feeling that life now completely lacks purpose and meaning.
The massive clinical cutoff here? Duration. Abnormal grief is strictly characterized by these intense symptoms dragging on for longer than 6 months. In fact, to fully and accurately assess a patient for pathological grief, clinicians will often require a full 12 months of grieving to have passed. This ensures they aren't accidentally pathologizing a natural mourning timeline, which is honestly a brilliant clinical safeguard.
So why do some people cross over into abnormal grief? The clinical vulnerabilities are actually pretty clear. Sudden and unexpected deaths are huge triggers. If the bereaved had a highly dependent or even a highly ambivalent relationship with the deceased, the risk skyrockets. Survivor insecurity, a prior psychiatric disorder, or even situational factors, like a survivor who has dependent children and feels like they just can't easily show their own grief, all of these make a patient far more vulnerable to developing this prolonged pathological state. It really shows just how much our environment dictates our ability to heal.
When it comes to management, the sequence for abnormal grief is highly structured. It ranges from deeply practical steps, like encouraging the viewing of the body and putting away belongings, which actually helps transition the brain from denial to acceptance, to advanced clinical interventions. Medications like hypnotics or anxiolytics are used very, very briefly, pretty much just for sleep. Antidepressants only come into play if the patient actually meets the criteria for depressive disorder in the second stage of grief. Ultimately, the gold standard intervention here is complicated grief treatment, or CGT, which is this really powerful combination of cognitive behavioral therapy and interpersonal therapy that focuses on psychoeducation and cognitive reconstruction.
So, we've covered the exact clinical pathways, right from day 0 of an acute stressor all the way to the 12-month markers of complicated grief, which leaves us with this final provocative thought. By strictly separating these diagnostic timelines, treating day 2 completely differently than month 6, are we ultimately better equipped to intercept these conditions early and prevent acute, temporary stress from hardwiring itself into permanent trauma? Think about that. Thank you so much for joining me for this explainer. I hope this detailed, structured look at the clinical data has clarified exactly how we diagnose and manage these incredibly complex disorders. Catch you next time.